Constipation is a heterogeneous, symptom-based disorder. It is defined as defecation that is unsatisfactory because of infrequent stools, less than 3 times weekly, difficult stool passage with straining or discomfort, or seemingly incomplete defecation. Stools are often dry and hard, and may be abnormally large or abnormally small. The Rome-4 diagnostic criteria for constipation include spontaneous bowel movements occurring fewer than 3 times a week. Stools are often dry, hard, or lumpy, and may be abnormally large or small. In practice, constipation is often defined as passage of stools less frequently than the person's normal pattern. Chronic constipation usually describes symptoms which are present for at least 3 months. Fecal loading impaction describes retention of feces to the extent that spontaneous evacuation is unlikely. Overflow fecal incontinence, previously known as encopresis or bypass soiling, is leakage of liquid stool from the proximal colon around impacted feces, where small quantities of stool may be passed frequently and without sensation. Functional, primary, or idiopathic constipation is chronic constipation without a known cause. Using symptom-based criteria, an international panel of experts classified this group into dyssynergistic defecation, paradoxical contraction or inadequate relaxation of pelvic floor muscles during defecation, slow transit, prolonged delay in passage of stool through the colon and/or poor propulsion during defecation, irritable bowel syndrome constipation. Secondary organic constipation is constipation caused by medication or an underlying medical condition, including endocrine, metabolic, neurological, or primary diseases of the colon. For example, stricture, malignancy, or proctitis. Rome-4 criteria categorizes disorders of chronic constipation into 4 subtypes. Functional constipation. B. Irritable bowel syndrome with constipation. C. Opioid-induced constipation. And D. Functional defecation disorders, including inadequate defecatory propulsion and dyssynergic defecation. The initial management approach for these disorders is similar, focusing on diet, lifestyle, and the use of standard over-the-counter laxatives. Risk factors for developing constipation include low-fiber diet or low-calorie intake, difficult access to toilet, or changes in normal routine or lifestyle, lack of exercise or reduced mobility, limited privacy when using the toilet, low educational levels or socioeconomic deprivation, a family history of constipation, psychological anxiety and/or depression, somatization disorders, eating disorders, history of sexual abuse, female sex, older age, pyrexia, poor fluid intake, dehydration, immobility, sitting position on a toilet seat, compared with the squatting position for defecation. Possible secondary causes of constipation include medications, aluminum-containing antacids, iron or calcium supplements, analgesics, such as opiates, up to 80% of patients, even with concomitant use of laxatives, and nonsteroidal anti-inflammatory drugs, antimuscarinics, such as procyclidine and oxybutane, antidepressants, such as tricyclic antidepressants, antipsychotics, such as amisulpride, clozapine, or quetiapine, antiepileptic drugs, such as carbamazepine, gabapentin, oxcarbazepine, pregabalin, or phenytoin, antihistamines, such as hydroxyzine, antispasmodics, such as dicycloverine or hyoscine, calcium channel blockers, such as verapamil, diuretics, such as furosemide. Organic causes: endocrine and metabolic diseases, diabetes mellitus with autonomic neuropathy, hypercalcemia and hyperparathyroidism, hypermagnesemia, hypokalemia, hypothyroidism, myopathic conditions, amyloidosis, myotonic dystrophy, scleroderma, neurological conditions, autonomic neuropathy, cerebrovascular disease, Hirschsprung's disease, multiple sclerosis, Parkinson's disease, spinal cord injury, tumors, structural abnormalities, anal fissures, strictures, hemorrhoids, escolonic strictures, for example, following diverticulitis, ischemia, or surgery, inflammatory bowel disease, obstructive colonic mass lesions, for example, due to colorectal cancer, rectal prolapse or recticell, postnatal damage to pelvic floor or third-degree tear, other, irritable bowel syndrome, slow transit constipation, pelvic or anal dyssynergia. Complications of chronic constipation include fecal loading and impaction, progressive fecal retention, distension of the rectum, and loss of sensory and motor function. Hemorrhoids or anal fissure. Complications of chronic fecal loading and impaction include fecal incontinence, which can be embarrassing and distressing. Chronic dilatation of the colon may cause megacolon, bowel obstruction, perforation, or ulceration. Recurrent urinary tract infections, obstructive uropathy. Rectal bleeding, rectal prolapse. The prognosis of chronic constipation is variable and will depend on the underlying cause. Patients often require weeks or years of lifestyle changes and laxative treatment. Constipation is not life-threatening but does affect quality of life. Fecal impaction may require emergency admission. Suspected diagnosis of constipation. If an adult presents with defecation, which is problematic because of infrequent stools, difficulty passing stools, or a sensation of incomplete emptying or anorectal blockage. Typically, bowel movements occurring less than 3 times a week may be regarded as constipation. There may be daily bowel movements, but associated symptoms such as excessive straining. Additional symptoms may include lower abdominal pain or discomfort, distension, or bloating. In practice, constipation is often defined as passage of stools less frequently than the person's normal pattern. Consider a diagnosis of constipation in the elderly if there are nonspecific symptoms, such as confusion or delirium, functional decline, nausea or loss of appetite, overflow diarrhea, urinary retention. Suspect a diagnosis of fecal loading or impaction if there is history of hard, lumpy stools, which may be large and infrequent, for example, passed every 7 to 10 days, or small and relatively frequent, for example, passed every 2 to 3 days. Having to use manual methods to extract feces, overflow fecal incontinence, or loose stool. If a diagnosis of constipation is suspected, ask about any red flag symptoms or signs that may suggest a serious underlying cause, such as colorectal cancer. These include a sudden change in bowel habit, rectal bleeding or bloody stools, weight loss, abdominal pain or iron deficiency anemia. What the person means by constipation and their normal pattern of defecation. The person's perception of a normal bowel habit may influence the diagnosis of constipation. The duration of constipation and the frequency and consistency of stools, such as hard, small, pebble-like, or large stools, for example. Do they block the toilet? Any nocturnal symptom. Consider the use of the Bristol stool chart to provide an objective record of the person's stool form. Associated symptoms such as rectal discomfort, excessive straining, feeling of incomplete evacuation or blockage, or rectal bleeding, abdominal pain or distension. Note: pelvic floor dyssynergia may be suggested by straining and a feeling of incomplete evacuation. Associated fever, nausea, vomiting, loss of appetite and/or weight. Associated urinary symptoms, urinary incontinence or retention, dyspareunia, any family history of colorectal cancer or inflammatory bowel disease. How symptoms affect the person and impact on quality of life and daily functioning. Any self-help measures or drug treatments tried, including over-the-counter medication and symptom response. To assess for any risk factors, ask about the person's diet, including fiber and fluid intake, normal routine or lifestyle, level of activity and mobility. The person's toileting habits, for example, feeling hurried or being disturbed when trying to defecate, withholding or ignoring the urge to defecate, access to the toilet at home or work, and level of privacy. Any associated psychological or mental health conditions, such as anxiety, depression, cognitive impairment, or an eating disorder. Any drug treatment or clinical features of an underlying organic cause of secondary constipation, and manage appropriately. To assess for fecal loading and/or impaction, ask about a history of fecal incontinence, For example, is underwear regularly soiled, excessive wiping, or loose stool? Whether the person has needed to use manual measures to relieve constipation. A finger having to be inserted into the vagina suggests a recticel. A finger in the rectum to push away a flap suggests a rectal ulcer. Pressure behind the anus may assist defecation if the levator muscles are weak. Digital rectal evacuation of feces confirms severe fecal loading and/or impaction. Obstructed defecation syndrome. Obstructed defecation syndrome, ODS, is characterized by an urge to defecate, but an impaired ability. Obstructed defecation syndrome is characterized by an urge to defecate but an impaired ability to expel the fecal bolus. Symptoms include unsuccessful attempts at fecal evacuation, excessive straining, pain, bleeding after defecation, and a sense of incomplete fecal evacuation. Women, especially multiparous women, are more likely than men to present with symptoms of obstructed defecation syndrome. Obstructed defecation syndrome is often associated with structural defects in the rectum, such as recticel, internal rectal prolapse, and perineal descent. Conservative treatments include diet, biofeedback, laxatives, and pelvic floor retraining. Surgery may be considered for patients not responding to conservative treatment or if a structural abnormality is present. Surgical options include stapled transanal prolapsectomy, perineal levatorplasty, stapled transanal rectal resection, and laparoscopic ventral mesh sacrocolporectopexy. Examine the person. Assess for signs of weight loss and general nutritional status. Perform an abdominal examination to check for abdominal pain, distension, masses, or palpable colon, suggesting retained fecal masses. Perform a digital rectal examination, checking for anal fissures, hemorrhoids, skin tags, rectal prolapse, recticel, skin erythema, or excoriation. This may be a sign of fecal leakage. Resting anal sphincter tone, rectal mass lesions, and retained fecal masses, which may also be felt on external perianal palpation. Note, a fecal mass can be distinguished from a tumor or cyst, as firm pressure exerted by a finger will typically leave a palpable indentation in hard faces. Pelvic floor dysfunction, if appropriate. While asking the person to bear down, there may be paradoxical contraction of the anal sphincter on straining. Leakage of stool, rectal or anal pain. Be aware that no investigations are usually required in an adult with functional constipation where there is no suspected underlying cause. Investigations. Most constipation does not need investigation, especially in young, mildly affected patients. Indications for investigation include age greater than 40 years, a recent change in bowel habit. Associated symptoms, weight loss, rectal bleeding, mucus discharge, or tenesmus. Possible investigations include blood tests, FBC, urea and electrolytes, calcium, thyroid function test, sigmoidoscopy, and biopsy of abnormal and normal mucosa. Barium enema if there is suspected colorectal malignancy. Special investigations, e.g., transit studies, anorectal physiology, which are occasionally indicated. Specialist investigations may include flexible sigmoidoscopy, colonoscopy, or computed tomographic colonography. Abdominal X-ray may identify fecal load, impaction, or obstruction. Anorectal manometry, defecation proctogram, and colon transit time studies with radio-opaque markers or a wireless capsule to determine which subtype of constipation is involved, such as slow colonic transit or pelvic floor dyssynergia. Specialist management may include biofeedback training by a physiotherapist for some defecation disorders, such as pelvic floor dyssynergia, which can teach people to relax their pelvic floor muscles during simulated defecation. Surgery, such as subtotal colectomy with ileorectal anastomosis, may be considered rarely in people with slow transit constipation, but only if all other treatment options have been ineffective. Self-management advice encourage the person or carer to manage their symptoms by giving advice on eating a healthy, balanced diet and having regular meals. The person's diet should contain whole grains, fruits and their juices, high in sorbitol, and vegetables. Fruits that have a high sorbitol content include apples, apricots, grapes, and raisins, peaches, pears, plums, and prunes, raspberries, and strawberry. Advise the person that the beneficial effects of increasing dietary fiber may take several weeks. The type of fiber is also important. Psyllium husk and coarse wheat bran fibers are more beneficial than finely ground wheat bran fiber. Drinking an adequate fluid intake, especially if there is a risk of dehydration, increasing activity and exercise levels. Helpful toileting routines. Advise on a regular, unhurried toilet routine, giving time to ensure that defecation is complete. Advise on responding immediately to the sensation of needing to defecate. Ensure that people with limited mobility have appropriate help to access the toilet and adequate privacy. Ensure the person has access to supported seating if they are unsteady on the toilet. Management of short duration, less than 3 months, constipation. Investigate, exclude, and then manage any underlying secondary cause of constipation. If appropriate and possible, advise the person to reduce or stop any drug treatment that may be causing or contributing to symptoms. This is more likely to be challenging in some elderly people where multimorbidity and polypharmacy are issues. Identify if fecal impaction is present, as this will need treatment to resolve and may need enemas, suppositories, or disimpaction. Advise on lifestyle measures, such as increasing dietary fiber, ensuring adequate fluid intake, and activity levels. Advising this a lifestyle change may improve constipation for the future and additionally improve quality of life and contribute to better general health. If these measures are ineffective or symptoms do not respond adequately, offer treatment with oral laxatives using a stepped approach. Offer a bulk-forming laxative first line, such as Espagula. Note: it is important for the person to drink an adequate fluid intake. If stools remain hard or difficult to pass, add or switch to an osmotic laxative, such as a macrogol. If a macrogol is ineffective or not tolerated, offer treatment with lactulose second line. If stools are soft but difficult to pass, or there is a sensation of inadequate emptying, add a stimulant laxative. If the person has opioid-induced constipation, do not prescribe bulk-forming laxatives. Offer an osmotic laxative and a stimulant laxative. Advise the person to gradually reduce and stop laxatives once the person is producing soft, form stool without straining at least 3 times per week. Arrange to review the person regularly, depending on clinical judgment. Manage chronic constipation. For the initial management of chronic constipation, consider: investigate and manage any underlying secondary cause of constipation. And if possible and appropriate, advise the person to reduce or stop any drug treatment that may be causing or contributing to symptoms. This is more likely to be challenging in elderly people where multimorbidity and polypharmacy are issues. Identify if fecal loading and/or impaction is present, as this will need treatment to resolve and may need enemas, suppositories, or disimpaction. Advise on lifestyle measures, such as increasing dietary fiber, ensuring adequate fluid intake, and activity levels. Advising a lifestyle change may improve constipation for the future and additionally improve quality of life and contribute to better general health. If the person has ongoing symptoms despite these measures, offer drug treatment with oral laxatives using a stepped approach. Adjust the dose, choice, and combination of laxatives used, depending on the person's symptoms, the desired speed of symptom relief, the response to treatment, and their personal preference. Offer initial treatment with a bulk-forming laxative such as Espagula. Note: it is important for the person to drink an adequate fluid intake. If stools remain hard or difficult to pass, add or switch to an osmotic laxative, such as a macrogol. If a macrogol is ineffective or not tolerated, offer treatment with lactulose second line. If stools are soft but difficult to pass, or there is a sensation of inadequate emptying, add a stimulant laxative. Consider treatment with prucalopride if at least 2 laxatives from different classes have been tried at the highest tolerated recommended doses for at least 6 months and failed to relieve symptoms. Where invasive treatments such as suppositories, enemas, rectal irrigation, and/or manual disimpaction is being considered. The prokinetic prucalopride stimulates gastrointestinal motility. Offer a prescription for 4 weeks, and if there's no symptom response following this trial, reconsider the benefit of continuing treatment. Manage fecal loading and/or impaction. The aim of management of fecal loading and/or impaction is to achieve complete disimpaction with minimal discomfort. Adjust the dose, choice, and combination of laxatives used, depending on the person's response to treatment and their personal preference. Following an assessment, if there are hard stools, consider prescribing a high dose of an oral macrogol. If there are soft stools or ongoing hard stools after a few days of treatment with an oral macrogol, consider starting or adding an oral stimulant laxative. If the response to oral laxatives is inadequate or too slow, consider prescribing a suppository such as bisacodyl for soft stools, glycerol alone, or glycerol plus bisacodyl for hard stool. A mini enema such as docusate, softener and weak stimulant, or sodium citrate, osmotic. Warn the person that diarrhea and fecal overflow may occur before disimpaction is complete. If the response to treatment is still inadequate, consider prescribing a sodium phosphate or a rachis oil retention enema, placed high if the rectum is empty but the colon is full. For hard stool, it can be helpful to give the arachis oil enema overnight before giving a sodium phosphate, large volume, or sodium citrate, small volume enema the next day. Enemas may need to be repeated several times to clear hard, impacted faces. Reinforce advice on lifestyle measures such as increasing dietary fiber, fluid intake, and activity levels to help maintain regular bowel movements and prevent recurrent fecal loading. Consider the need for regular laxative use to maintain regular bowel movements, or the use of intermittent laxatives for episodes of fecal loading. Arrange to review the person every few days to assess the response to treatment, depending on clinical judgment. Manage constipation in pregnancy and breastfeeding. For the management of constipation during pregnancy, advise on sources of information and support, such as the UK Teratology Information Service Patient Information Leaflet Treating Constipation During Pregnancy. Available at www.medicinesinpregnancy.org. Advise on lifestyle measures, such as increasing dietary fiber, fluid intake, and activity levels, as appropriate. If these measures are ineffective or symptoms do not respond adequately, offer short-term treatment with oral laxatives. Adjust the dose, choice, and combination of laxatives used, depending on the woman's symptoms, the desired speed of symptom relief, the response to treatment, and their personal preference. Offer a bulk-forming laxative first line, such as ispagula. If stools remain hard, add or switch to an osmotic laxative, such as lactulose. If stools are soft but difficult to pass, or there is a sensation of incomplete emptying, consider a short course of a stimulant such as senna. If the response to treatment is still inadequate, consider prescribing a glycerol suppository. Managing severe constipation. For patients who fail to respond to conservative measures, other options may be considered. These include transinal irrigation. Water is introduced into the rectum by a catheter with inflatable balloon. It is controlled by a manual unit and has a pump, leg straps, and a bag to hold the water. It is self-administered by the patient. A number of systems are available, e.g. peristine sacral nerve stimulation, a minimally invasive procedure whereby an electrode is placed in a posterior foramen of the sacral bone, the Malone operation. This is also called an antegrade colonic enema, ACE. A small stoma is constructed from the appendix. Through the appendicostomy, a catheter is inserted to administer an enema in the cecum. Usually 1 ml are given every second day to empty the whole colorectum. In patients who no longer have the appendix, a neoappendix can be created from ileum or part of the cecum surgery. Colectomy with ileorectal anastomosis is reserved for a very small number of patients who do not respond to any other measures. Follow-up in primary care. Arrange regular follow-up of the person depending on clinical judgment. If oral laxatives have been prescribed, advise that laxative should not be stopped suddenly, and weaning may take several months. The rate of laxative dose reduction should be guided by the frequency and consistency of stool. Laxative doses should be reduced gradually. For example, after 2 to 4 weeks when regular bowel movements are comfortable with soft form stools. This is to minimize the risk of requiring rescue laxative treatment for recurrent fecal loading and/or impaction. If a combination of laxatives has been used, reduce and stop one laxative at a time, starting with stimulant laxatives if possible. Note, it may be necessary to also adjust the dose of other laxatives used to maintain regular bowel movements.